Good morning. My name is Madeline Jankowski, and I'm one of the lead cardiac sonographers at Northwestern Memorial Hospital in Chicago. I've been in the field for almost 6 years. I find the heart one of the most fascinating organs to care for and image. I've spent my career mastering transthoracic and stress echo, as well as volunteering for the American Society of Echocardiography and American Registry for Diagnostic Medical Sonography. Today I'll be talking about mitral regurgitation with a heavy focus on scanning techniques for sonographers. Mitral regurgitation is a very common pathology with a variety of causes. These causes, though, can be broken into two groups, primary and secondary, or maybe you'll hear organic and functional. With primary or organic MR, the valve is the problem. It could be because of the structure of the valve, like myxomatous changes or congenital abnormalities. It could be also something acquired, like an infection or degenerative disease. These changes in the mitral valve can lead to a sick ventricle. In secondary or functional MR, it's the ventricle that's making the valve sick. This could be from a dilated cardiomyopathy stretching the annulus out, or maybe a tethered leaflet from ischemic heart disease. It's important to identify the mechanism or the reason for the mitral regurgitation to help diagnose and then treat the patient accordingly. But whether it's primary or secondary, as sonographers, we need to know how to show the mitral regurgitation and its associated findings. There are some crucial images that need to be taken to best quantify mitral regurgitation on echo. Many of these images are part of the standard of care protocol, but we just need to ensure that they are closely looked at. First, we need to make sure to look at the mitral valve in every view. The parasternal long and short axis images can provide us a first look at the valve and the mechanism of MR. Then we can move to the apical 4, 2, and 3 to better assess the jet. These images should be taken first just with 2D imaging to get a sense of the valve structure. Then we can turn on the color Doppler to assess the MR. To ensure a good color Doppler result, I like to try to keep my color frame rate above at least 20 megahertz if I can. I can adjust the size of my color box or 2D sector to help and achieve this. Next, we need to assess the valve with spectral Doppler. A continuous wave Doppler through the valve can show us the timing of the MR. It also shows the density of the jet, which can help in grading severity. Next, we can use our pulse wave Doppler at the leaflet tips to get a mitral inflow. I like to keep my sample volume at 2 centimeters. We look for increased E wave velocity with significant MR. The pulse wave of the pulmonary veins can have a sample volume of 3 to 4 centimeters. This will help show if there's blunting or reversal of systolic flow. Pulse wave of the LVOT can help calculate the stroke volume of a patient, needed to see how much flow is going out of the heart versus back into the left atrium. Finally, biplane volumes of the left ventricle and atrium are important to see the remodeling effect that MR may have caused. Be aware of the ejection fraction, though, as a normal LVEF for patients with significant MR is higher than normal, around 60%. The ASC guidelines for quantifying MR are pretty standard across labs. This table and the rest of the guidelines will help you decide whether the MR is mild, moderate, or severe. When physicians are reading these studies, it's really important to include both the mechanism of the MR as well as the severity. This will help guide treatment in the future. PISA, or proximal isovolumetric surface area, is another calculation we can do to quantify mitral regurgitation. We measure a PISA radius to calculate how big the hole is that the blood is going back through. To do this, we need to really hone in on the valve. I first zoom on the mitral valve, excluding most of the atrium so I can see the leaflets clearly. Next, I shift the baseline of the color Doppler down to around 40 centimeters per second. This makes the calculation a little easier. We want to shift the baseline in the direction the regurgitant jet is going. Next, I like to take a longer loop, more than 2 beats, to clearly show the radius over a few cycles. This way, I have a few to choose from to measure, and the physicians do too. Finally, we want to freeze the clip when the radius is the largest and measure it. So in this image that we're looking at, we can see the PISA radius start to develop right above the leaflet tips, that little yellow hemisphere. Now we'll go through two cases to use what we've learned to assess the MR. Our first patient is a 37-year-old male who presents with a murmur and no symptoms. On the first image, we can see the mitral valve does not look normal. When we put the color on, we see there is at least some mitral regurgitation. We need to assess further to see if there is more than mild MR. The M mode of the mitral valve shows the dip in the leaflets and systole, indicating mitral valve prolapse. In the short axis, we see the myxomatous changes of the mitral valve. I like to take quite a few images at this level of the ventricle, slowly moving from the mitral to the aortic valve. In image 1 in the top left, we barely see any MR. As we move up the ventricle, we start to appreciate that there is significant MR. In image 2, we can start to define the origin of the jet at A2P2 in the middle of the valve. As we move up the ventricle in images 3 and 4, we can appreciate the eccentricity of the jet directed anteriorly. Here we can appreciate the valve from the apical forechamber. We can see that there hasn't been much ventricular remodeling and the LVEF has been preserved. After putting color on the valve in the forechamber, we can appreciate the eccentricity of the jet. But the image on the left does not show the jet the best. As sonographers, we must follow these eccentric jets and try to show them in full. A small adjustment was made to get the whole jet in the image on the right, from the leaflet tips to the end of the jet. Our spectral Doppler shows a slightly increased E velocity at the leaflet tips on the left-hand side. The pulmonary vein systolic flow is at least blunted and most likely reversed. I like to show the image both above and below the baseline to ensure that we're seeing everything. Look out for your machine settings going into the high PRF mode when doing pulmonary veins. This can be avoided by having an appropriate scale on your spectral Doppler or even decreasing the depth on your 2D image. When there is a very eccentric jet, I like to take multiple images of the continuous wave through the mitral valve. This way, I can try it again if I feel I'm at a better angle to the jet. This helps us determine the timing of the jet. This one is holosystolic. Many mitral valve prolapse jets will be in late systole only. Here's another example of being able to follow the eccentric jet. The image on the left is a normal two-chamber image. I had to make small adjustments to my image to get the whole jet in. The two-chamber is also really important to determine the origin of the jet. This view looks at the valve across the commissures. We can see the origin is in the central aspect of the coaptation line. I like the three-chamber view for many eccentric jets. It seems to be the easiest to tease out the whole jet. On the right, I've zoomed on the valve to perform PISA. Before even shifting my baseline, I can start to see a PISA hemisphere. I'm at about 63 centimeters per second. This is another clue that can lead your mind to severe MR. We didn't even need to change the aliasing velocity to bring out that PISA hemisphere. When performing PISA, I like to do it in all three apical views. This shows the 4 and the 3. I have zoomed on the valve and shifted my baseline down. As we can see, these hemispheres are huge. Be aware that this may even overestimate the severity because the equation squares this radius. Without the baseline shift, I was still able to bring out a large PISA radius of 1 centimeter. So I'm at 63 centimeters per second, and I still measured that 1 centimeter radius. I like to do the color suppressed after my measurement to ensure that I am measuring my radius at the right spot. 3D and biplane or triplane imaging can also be really useful to visualize these valves, if that is available at your institution. The image on the left is a cropped 3D image of the mitral valve, showing the prolapse beautifully. The image on the right is using triplane to look at the eccentric jet. This can also be used to see PISA in all three views at once. This study was read as having severe MR secondary to posterior leaflet mitral valve prolapse. From this study, we can take home a few important pieces of information. We need to really search for and go after the eccentric jets. Using standard views may not always show the jet in totality, and we may miss something big. Every view is important when diagnosing MR. I especially like the parasternal short axis and two-chamber images to help define the jet origin. Finally, our spectral Doppler helped us push us into the severe range by our holosystolic continuous wave jet and the reverse systolic pulmonary veins. Our second case is another common mechanism of MR. This patient is a 76-year-old male with a history of hypertension and hypercholesterolemia. He presented at an outside hospital with shortness of breath and feeling overall sluggish. An echo showed severe MR and the regional wall motion abnormalities in the RCA territory. He went on to have a cath that showed that he did indeed have RCA disease as well as lesions in the LAD and diagonals. They placed a bare metal stent to his RCA and he was referred to Northwestern to be evaluated for cardiac surgery. The first look at the parasternal long axis and short axis of the mitral valve gives us a first look at this gentleman's valve and the wall motion abnormalities. We can see the posterior wall is akinetic, but the LV function is relatively preserved. In this short axis, we see another regional wall motion abnormality in the inferior wall, as well as get a good look at the valve. With first glance at this valve, we can see there are no myxomatous changes or rheumatic disease, so we can start to think towards secondary MR. The color of the mitral valve in the long axis gives us a first look at the severity and the direction of the jet. We can see this is eccentric and directed posteriorly. The short axis is a very important and sometimes forgotten view when evaluating mitral regurgitation. This is the first view we can identify the origin of the jet and also the jet width. We can see this jet is pretty central, arising from A2P2, but the jet is also pretty wide. I like to start imaging the mitral valve at the leaflet tips like these two images. A good habit to get into for sonographers is to take images moving from the mitral valve to the LVOT. You can do this in separate clips as seen here, or capture a longer loop and sweep from the mitral valve to the LVOT. This way we are sure to capture the tips of the mitral valve to see the origin, but then we can see where this jet is directed as we move up to the LVOT. We get a sense on how much of the left atrium this jet fills up. In our apical images, we see the wall motion abnormalities more clearly that are the cause of this mitral regurgitation. We see scarring in RCA territory, which makes sense because that's where he had the most disease. Unfortunately, the stent put in did not revascularize the wall, so the defect is still causing the MR. In a lot of cases of ischemic heart disease, sonographers might consider using echo-enhancing agents to better define the regional wall motion abnormalities. Although it really helps to define the endocardial border, those agents do not help with looking at valvular pathology. We can visualize the full extent of the jet in the apical views, seeing how far it goes into the left atrium. We can see the jet going into the pulmonary veins, which gives us a heads up when using the pulse wave later. Take a look at the scale. It's at 52 centimeters per second, and we can already start to visualize a PISA hemisphere. We know this MR is very significant because we can see a PISA radius without even doing a baseline shift. If we were doing a PISA calculation, I like to start by zooming in on the valve so that you can measure the radius easily. I'll take one moving clip of the baseline shift, take one clip of the baseline shift with color compare, and then freeze it to do my measurement. These images help the reading physician know where the valve is so that the radius can be accurately measured. When shifting the baseline for PISA on transthoracic echo, shift the baseline down to around 40 centimeters per second. You'll see a hemisphere that the PISA makes. These spectral Doppler tracings are some of the most important when evaluating MR. Our continuous wave in the top right shows us the timing and density of the jet. This is obviously pretty dense because of the severity. A peak velocity or BTI of the MR jet is also necessary for PISA calculation. On the left, we see the pulse wave of our pulmonary veins. Because of the color image before, I expected to see systolic reversal, and there it is. A pulse wave at the mitral valve tips is also important to see if there are increased E-wave velocities. The two-chamber apical view is another forgotten view that we can use to understand where the jet is coming from and the width of the jet, like the parasternal short axis. It shows us a cross-commissural view, telling us that the jet is very wide, going from medial to lateral commissures. The three-chamber on the bottom right also lets us see the full jet. I like to take an image with just color, but then use the color compare on a second image to see what the valve is doing at the same time. Because there are different treatment options for this patient, including percutaneous valve repair, we ordered a TEE to better visualize the mechanism and also localize the lesion. The four-chamber and long axis views gives us a look at how eccentric this jet is, and we see a PISA hemisphere at around 60 centimeters per second without shifting the baseline. Baseline shift was still done, but on TEE, we need to remember that the baseline shift is in the same direction of the jet, which this time is up. When we did the shift, we see our PISA radius is huge and most likely overestimated. On the bottom, we confirm again that there is systolic reversal in the pulmonary veins. This two-chamber view is similar to that on transthoracic, showing us a cross-commissural view that helps us see the origin and the width of the jet. In the image on the top left, we really appreciate the restriction of the posterior leaflet and the override of the anterior leaflet. We can see the hole that the MR is going through. The 3D on the bottom right also helps us better visualize the override of that anterior leaflet. This patient went on to have mitral valve replacement as well as bypass. This was a great showcase of severe functional MR caused by ischemic disease. Some things to remember are echo-enhancing agents do not help with valvular pathology. It's good to define the borders of the endocardium, but it will not bring out mitral regurgitation. In both cases, we used PISA to help define the severity. Also in both cases, the MR was so severe that a baseline shift was not needed to bring out an aliasing velocity. When using PISA in your own cases, shift the baseline in the same direction of the regurgitant jet to around 40 centimeters per second. Finally, utilize the short axis of the mitral valve and the two-chamber to help assess the origin and the direction of the jet. This will help other sonographers performing serial echoes to find the MR, but also to help when sending these patients for surgical repair. In addition to transthoracic, both stress echocardiography and transesophageal echocardiography can be helpful in fully diagnosing a patient. With stress echo, we can look at hemodynamic changes by looking for an increase in MR and also an increase in pulmonary pressures. Stress echo also gives us a sense of the patient's functional capacity and if they're actually developing symptoms. Transesophageal echo is very useful when transthoracic imaging can be very technically difficult and we can't get a good look at the mitral valve. Because the esophagus sits right behind the left atrium, we get a clear view of the valve and can better define the mechanism of MR. This can be very useful for patients that are getting evaluated for surgery so that the surgeon knows what he or she is getting into. Thank you so much for your time and interest in echocardiography and the mitral valve. I hope this lecture has provided some useful tips for scanning your next patient with mitral regurgitation. Have a great day.